Welcome to meeting number 6 of the Special Joint Committee on Medical Assistance in Dying. Pursuant to the order of reference of the Senate Chamber adopted on February 26, 2026, the order of reference of the House of Commons adopted on February 13, 2026, the Special Joint Committee is meeting to study the eligibility of medical assistance in dying for those whose sole condition is mental illness. Today's meeting is taking place in a hybrid format. Pursuant to the standing orders, members are attending in person in the room and remotely using the Zoom application. I'd like to confirm that sound tests have been made successfully. Before we continue, I would ask all persons participating to consult the guidelines written on the card on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including interpreters. You will also notice a QR code on the card, which links to a short awareness video. I'd like to make a few comments to the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. For those on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through myself, the chair. For members in the room, if you wish to speak, please raise your hand. For members on Zoom, please use the raise hand function. The clerk and I will manage the speaking order as best we can, and we appreciate your patience and understanding in this regard. Tonight, I would like to welcome a whole bunch of new Liberals over there. Greg, Wade, Elizabeth, Peter, welcome to the committee. I'd explain who's who, because some are here permanently, some are not here permanently, but it gets too complicated, so I'm just going to forego all that. For the first hour, we have 3 people testifying. In the room, Professor Brian Mishara, Director, Center for Research and Intervention on Suicide, Ethical Issues and End-of-Life Practice, Université du Québec à Montréal. Online, Center for Addiction and Mental Health, Dr. Sanjeev Sockalingam, Senior Vice President, Education and Chief Medical Officer by video conference. You will each have the floor for approximately 5 minutes, as there's only 2 witnesses. You can go a little bit over. I will just raise a piece of paper when you have about 30 seconds so you know your time's coming to an end. With that, maybe we'll start first with Dr. Professor Mishara in the room. You'll each have your 5 minutes, and then there will be a series of questions. So, Professor Mishara, you have the floor.
Honorable Senators and members of the committee, I've spent my life working in suicide prevention. I was president of the Canadian Association for Suicide Prevention and the International Association, founder of the Quebec Association for Suicide Prevention, and I work with the World Health Organization in training, research, and policies. I believe that MAID should be available when suffering is not remediable by other means. However, in the case of mental illness, this is not possible to determine. I believe that suicides are preventable, even in seemingly hopeless situations. And I agree with the position of the International Association for Suicide Prevention that the overlap between MAID requests and suicide makes it impossible to distinguish between them. And that MAID for mental illness will undermine suicide prevention by communicating that death is a viable alternative to treatment. I don't think I have to say much about irremediability. Other people have talked about its impossibility to be determined with mental illness. No one can accurately predict whether a patient who failed to respond to multiple past treatments will respond to the next treatment or not. Mental health diagnoses change. They are unfortunately unreliable. Common diagnoses like schizophrenia. If you ask 2 psychiatrists to independently make a diagnosis, in about 1 out of 7 patients, They will make different diagnoses, which means that many people get the wrong treatment unless or until their diagnosis is corrected. 86% of mental health patients have at least 2 diagnoses over 34 years. According to research, no one virtually gets and keeps one pure diagnosis type. We have an obligation to provide access to mental health treatment before providing access to MAID. The Canadian Institute for Health Information in 2025 found that 41% of adults with a mental illness said that their needs were not met at all or only partially. 52% of young adults reported not being able to obtain any or only limited help for their mental illness, and 1 out of 3 Canadians say that they did not have access to mental health services because they are unable to pay the costs. Some believe that requests for MAID are more reasonable or rational, and this can be distinguished from suicide. However, there is no discernible difference between the reasoning in MAID requests for mental illness and justifications given for suicide. And both people feel their suffering is interminable and intolerable. Moreover, most important human decisions are emotional, not rational or reasoned. What's the most important decisions we make? Who we marry, career choice, even what type of car we buy. We cannot expect that while we are suffering from a mental illness, and mental illnesses can cloud one's thinking, things should be any different than other important decisions we make. I held the Boer-Alaskan Canadian National Fellowship in Human Rights Research to study euthanasia in the Netherlands, where MAID for mental illness was legalized in 2002. Each year, only 1 or 2 requests were approved. However, recently, after news stories about people with depression who received euthanasia, requests skyrocketed in 2023 with 138 deaths, and in 2024 it went up 60% more with over 7,000 requests and 219 deaths. Most of the people who died and who requested it were depressed women living alone under age 24. Alarmed psychiatrists petitioned the government to stop this practice. They said, introducing euthanasia as a sanctioned outcome reframes suicidality from a symptom requiring containment into a potential treatment endpoint and as an acceptable treatment plan. I don't want this to happen in Canada.
Thank you, Professor. Dr. Sockalingam for 5 minutes.
Thank you, Chair and members of the committee, for the invitation to appear today. My name is Dr. Sanjeev Sockalingam, and I am the Chief Medical Officer, Senior Vice President Education, and Senior Scientist at the Center for Addiction and Mental Health, CAMH. CAMH is Canada's largest mental health teaching hospital and one of the world's leading research centers in this field. I also oversee our medical assistance in dying service here at CAMH. Over the past number of years, CAMH has made several submissions to government committees related to medical assistance in dying and mental illness. Our position has been and remains that we are concerned about the expansion of MAID to people whose sole underlying medical condition is mental illness. We want to be clear that this position is not based on the belief that suffering caused by mental illness is not comparable to suffering caused by physical illness. The grievousness of an illness is subjective, and there is no doubt that for some people, mental illness can be grievous and cause physical and psychological suffering. The irremediability of an illness, however, is an objective determination that must be based on the best medical evidence available. And right now, there are currently no established criteria or consensus among psychiatrists for if or when a mental illness should be considered irremediable. That is because there is no evidence in the mental health field at this time to predict the trajectory of any one person's mental illness and to ascertain whether an individual has an irremediable mental illness. And this has been discussed previously. Therefore, any determination that a person has an irremediable mental illness for the purposes of MAID would be inherently subjective and arbitrary. In an attempt to address this problem, the Canadian Psychiatric Association, CPA, recently published initial guidance designed to help MAID assessors identify if a person has an irremediable mental illness. I know this has also been discussed by this committee. We appreciate the CPA's efforts to create clarity around the process of an assessment. However, it does not address our call for creation of guidelines summarizing the evidence gap. Specifically, the guidance document does not offer MAID assessors with evidence-based criteria that could be used to determine the trajectory of a person's mental illness. And the CPA guidance only provides recommendations on a process to follow for assessing a person's mental illness. And this leaves the guidance open to individual interpretation and could put people with mental illness at risk of accessing MAID when they do not actually meet the eligibility criteria. The lack of evidence for how to objectively determine the irremediability of an individual's mental illness is a primary reason we remain concerned about the potential for MAID to be extended to people whose sole underlying condition is mental illness. And this concern is compounded by disagreement amongst physicians on if or how a request for MAID can be differentiated from suicide intent, which is an extremely difficult task for psychiatrists. In fact, a new review of the research literature found no evidence to suggest it is possible to reliably distinguish between the factors underlying a request for MAID and those underlying suicide intent. While the CPA's first edition of MAID clinical guidance has a section on managing suicide risk across all phases of the MAID pathway, it does not provide concrete methods for helping clinicians to determine if the request for MAID is due to acute distress, a symptom of a mental disorder,
Sorry, Dr. Sockalingam, there's an issue, I think, with translation.
Oui, Monsieur le Président. Si le témoin peut juste ralentir un petit peu parce que c'est difficile pour les interprètes de maintenir le rythme.
It's very difficult for the interpreters to follow.
So it'd be
Would you like
easier
me
for
to slow down a little
interpreters
bit?
Yeah, please.
Okay.
We'll give you a few extra seconds at the end.
Okay, thank you. Thank you. Would you like me to repeat any previous statement, the last paragraph? Would that be helpful?
Maybe, how about the last paragraph?
Yeah. So as I was saying, a new review on the research literature found no evidence to suggest it is possible to reliably distinguish between the factors underlying a request for MAID and those underlying suicide intent. And while the CPA's first edition of MAID clinical guidance includes a section on managing suicide risk across all phases of the MAID pathway, it does not provide concrete methods for helping clinicians determine if the request for MAID is due to acute distress, a symptom of a mental disorder, or an enduring desire to die. Finally, but of utmost importance to extending MAID to people whose only medical condition is mental illness, is the state of mental health care in Canada. We've heard mental health has been and continues to be significantly underfunded compared to physical health care in our country, making it difficult for people to get the right care when and where they need it. Demand for care continues to grow while service capacity does not. 1 in 3 Canadians report that their needs for mental health care are unmet or only partially met. In Ontario alone, over the last 4 years, mental health service volumes have increased by 66%. Access to mental health treatment also remains inequitable. That is why investing in mental health care and support should be the priority before any consideration is given to moving ahead with implementing a track to choose MAID. In sum, only when we have evidence-informed, consensus-based criteria for determining the irremediability of a person's mental illness and for distinguishing between a request of MAID and suicide intent, and only when such criteria could be introduced into a well-resourced mental health system, would it be possible to offer safe, adequate, and equitable MAID services to people whose sole underlying condition is mental illness. And that is why CAMH recommends that the federal government delay indefinitely the extension of MAID eligibility to people whose sole underlying condition is a mental illness. We are at CAMH are happy to offer expertise to the government, including sharing our recent evidence synthesis on irremediability, suicide, and MAID, and the gaps in the evidence base when available. Thank you.
Let me say, I think we'd be happy to, if you want to submit that, we'd be happy to receive it. Now we go to our first round of questioning with Mr. Lawton for the Conservative Party for 5 minutes.
Thank you very much, Mr. Chair, and thank you, witnesses, for your very, very fascinating and well-informed testimony. I'll be devoting my time to asking you questions, Dr. Sockalingam. I just want to put a fine point on how you ended there. Your position, or CAMH's position, rather, is that we should delay indefinitely the expansion of MAID for mental illness as a sole underlying criterion. That's correct?
That is correct.
We have heard testimony overwhelmingly from psychiatrists in particular that have alluded to the very things you've alluded to here, that there is no reliable way to distinguish between suicidality as a symptom of mental illness and a good faith request for MAID. We've heard the impossibility of coming up with a standardized framework that would assess irremediability for mental illness. Would you say from your experience that we have as close to a consensus as possible from mental health care practitioners of these points?
I would say so. And again, we've done our own assessments within our institution, and this is what has come forward as a majority in terms of some of the concerns. And I would say, again, it's due to the lack of evidence that we have to really delineate between suicide intent and the request for MAID. And as you articulated, our ability to prognosticate irremediability is significantly limited, given changing diagnoses, diversity and access to treatment based on geographic region or sociodemographic factors, but also in terms of predicting response.
So, I mean, obviously on a very charged subject, it can be very difficult to find consensus, but we do actually have a fair amount of consensus to delay the expansion. My question to you is, looking at what CAMH said in 2024, or ahead of 2024 rather, that 2024 was too soon. The government delayed it and delayed it again. Here we are with an extension yet again to 2027. You are saying that we should delay indefinitely. Is your view that these issues can ever be resolved, or should we be really looking at a permanent cessation of this and end this practice of kicking the can down the road and just saying that by design this could never work?
I think that's you're asking me to prognosticate on the research and science of mental health conditions, and I don't think I can definitively say when or the timeline for us to really tackle and articulate some of the key things, particularly around irremediability, for example. I think we are suggesting indefinitely, and I apologize if there's I'm at the hospital right now and there might be an announcement overhead, so apologies if there's any distortion here. I would say for irremediability, I would say that we do not have sufficient evidence to prognosticate. There are still debates on diagnoses and differentiation of diagnoses among psychiatrists and assessment. And until we have a solid research to identify people's trajectories, biomarkers, and improve our diagnostic assessment tools and clinical assessment tools, I think the notion of providing safe guards for MAID for mental illness will be severely limited. And I'm not, why we're saying indefinitely is because the timelines for that to occur, for the evidence to mature and to have that stability and safety will take a significant amount of time. So kicking the can, as you said, down another 3 years, I don't think will substantially make a difference because we need to invest in research
Thank you.
significantly.
Some of the testimony we've heard from people who are not on the front lines of seeing patients with severe mental illnesses as you are, but some of the witnesses who have approached their testimony more from the realm of legal theory have said that, we can't discriminate between physical illness and mental illness. Now, CAMH in its 2023 submission said that mental illness, healthcare for mental illness is not comparable to care for physical illness. And I don't take from that you were saying that the two are unequal on a moral level, but in a practical sense, there are significant differences there. Just in the 30 seconds I have left, could you please elaborate on that in this context? You're muted, doctor.
I'll be very brief on that. And in some physical health conditions, we have diagnostic markers, lab tests that we can do to confirm a diagnosis and prognosticate someone's response to treatments. We are not there in mental health and for mental illness. And in particular, mental illness is more defined by differences in inequities in terms of access to treatments as well that are probably more pervasive given the nature of the illness and socio-demographic factors that are impacted.
Thank you, Mr. Lawton. Now for 5 minutes, Ms. Tezer-Dirksen.
Thank you very much, Mr. Chair, and thanks so much to our guests who are here today. I want to follow along with what Dr. Sockalingam was talking about with respect to the CPA guidance document, which I've reviewed. And in particular, I want to talk a little bit about Section 2, which was the guidance for assessing and managing the suicide risk of the requester. And I've written down here a portion of the document which noted that jurisdictions that allow assisted dying for persons with mental health disorders as the sole underlying medical condition have found that most requesters have a history of suicidal ideation and or suicide attempts. However, the presence of a history of suicidality does not prevent the requester from being eligible. So I'll ask you, Doctor, in your opinion right now, and you've kind of touched on it a little bit, but my question is, do clinicians and providers have the tools available to make these assessments and determine them with some degree of accuracy, particularly given in a more historical context of previous suicide attempts?
Yes, I think a great question. I think in the context of previous suicide attempts, I think much of our assessment is retrospective as it relates to mental health conditions and prognosticating from that standpoint. I do think from the standpoint of using past suicide attempts or suicidality, it is difficult to untangle what the current request for MAID is from an active suicidal ideation or intent, because it's so intricately embedded in some of the major mental illnesses like depression, high rates of suicidality in patients with schizophrenia or psychotic illness as well. So what I would say is it is difficult for us to entangle that on the front lines in terms of whether someone's request for MAID is in fact no longer part of that past suicide intent, and is it part of their current suicidality, really difficult in the front lines, and I would say validated by our clinical experience as well in our clinical setting.
Okay, thanks for that. And I know you had mentioned that with respect to understanding or untangling irremediability and untangling suicidality with a more reasonably based request, the research is kind of still out. Is there research underway? Like, is there a plan? Are researchers actually looking at these, you mentioned biomarkers and different things. Like, how developed is the research right now? Or is this something that we're not going to see for decades?
That relates to the previous question as well, that I think we have some signals of where we might be able to do research. We continue to request more funding and resources to do that research, to advance it, but it is still in the preliminary phases. And for it to be widespread into clinical practice, that is why we are recommending suspending this indefinitely, because of the time needed for that research to evolve.
Thank you. And you mentioned funding, and that oftentimes some of these discussions come down to that. I do want to ask, because it's within the scope of this committee, it's a particularly important scope of this committee to determine whether or not provinces and territories are ready to offer these services, provide the assessments, whether they have capacity to do the assessments. So I'll ask on that basis, you mentioned funding already, but aside from funding, in your opinion, the provinces and territories that in Ontario where you have experience, have you seen a willingness of the province to address this, or does it appear that they are still far away from implementing the systems and guidance that are needed for clinicians and providers to make adequate decisions?
Adequate decision about MAID for mental illness I actually sat on our provincial committee to tackle this question with our government, our Center of Excellence for Mental Health and Addictions, and a local network as well, committee of our major hospitals, to tackle this very question, and co-chaired that local committee. And in fact, we advocated for consideration when there was a high likelihood or a push to consider MAID for mental illness implementation a couple of years ago. We were worried and really wanted safeguards in place and resourcing because of the concerns I'm expressing today. And there was not a willingness to put resources forward. And in fact, one of our other concerns is that this pathway if it were to come to fruition, would be a way for people to bypass the long wait lists for mental health treatment to get assessment. They would actually get assessment faster in some cases than those who are waiting years for mental health assessment and treatment. And so we really need to think about the pressures in our healthcare system, how we would prioritize something like this versus providing and rolling out treatments that are effective for treatment-resistant depression, for example, which really links to irremediability. And so these are the kind of ethical but financial considerations we have to make as a system as well.
Thank you. Madame de Bellefeuille, vous avez la parole pour...
Ms. de Bellefeuille, you have the floor for 5 minutes. Thank you very much, Mr. Chair. My questions will be for Mr. Mishara. You undoubtedly understand what I'm trying to express here. If I have a chronic illness that's incurable, persistent, I can make the choice to die with dignity and choose medical assistance in dying. If I get a diagnosis of dementia, Alzheimer's, and I'm a Quebecer, I can have an advance directive to die in dignity when I don't want to die in a long-term care home. I want to recognize my children and husband. I don't want to be incontinent and have bad quality of life, even in a long-term care center. I have the right to choose. The law allows it. But if I'm schizophrenic and I'm under the care of a psychiatrist and I'm well medicated, I'm followed by the team of my CLSC, and my loved ones are with me, but that despite all that, I'm suffering. I've been suffering for many years. Well, I come to the conclusion that I don't have the same rights as other citizens who are in a situation of suffering because psychiatrists, doctors can't agree on a clear framework to determine whether my cure is still probable. Maybe other attempts can be made so that I suffer less. What bothers me, doctor, is to create categories of citizens who don't all have the same rights. I understand the question of how it's more difficult to decide whether someone with that kind of history can obtain MAID if their only problem is a mental disorder. But right now, as we speak, there are people who could obtain it because they have everything required but don't have the same rights as others. That bothers me. What can you tell me to try to have me understand that those people are not being discriminated against? Right now, it's not true that there is no research. There's lots of research. But all the research to date indicates that no one can really know whether in 6 months or a year or with a different treatment, that person will not be very glad to be alive. Given difficult access to medical treatment for mental health, we have an obligation to do everything to prevent suicide. Any person who attempts suicide thinks exactly like the person that you're describing right now. The person thinks, I can't continue to suffer this way. Death is the only way to stop my suffering. And there's nothing to be done. But almost always, we can, in fact, prevent suicide. I'm not talking about that. I'm giving you an example here. Somebody with schizophrenia, who's been treated for 25 years, who's medicated, who's well surrounded. As a legislator, I feel uncomfortable not listening to that person and their will to say, I've had enough. I'm suffering every day despite all the help I'm getting. I'm wondering what I can say to that person. That person needs to hear the message that everything will be done to help them. That person needs access to good diagnosis services. Yes, I'm sorry to interrupt you. I only have 5 minutes. But you're taking something for granted here. I've seen people in my office who had consulted doctors, who had intensive follow-up in mental health for 20, 25 years, and who are still suffering and remain suffering. So I'm saying those people, why aren't they authorized to be taken into consideration as a full-fledged person who can make choices? These are personal choices that concern them. When you've been treated for 25 years by a psychiatrist, you're getting medication, you have loved ones who are helping you, but you continue to suffer. What kind of hope can I give those people? Well, I think that person could speak to many others who've testified before the Parliamentary Commission in Quebec. Quebec decided not to allow MAID for people whose sole medical issue is mental disorder. We had testimony from people who were exactly in the situation you've described and who said before the committee, if MAID had been accessible for someone with a mental health problem, I'd be dead because I meet all the requirements 3 years ago. But now I'm very glad to be alive. I got proper treatment. And if we could predict who would be glad to be alive in a year or 2 years and who will continue to suffer, that would be another matter. But up till now, all research indicates that's not the case. And even research on schizophrenia indicate that the symptoms can reduce with age.
Et ça, c'est l'autre.
After that, the next person on the list is Senator Dalphon for 3 minutes. Good evening. Thank you for being with us, to all our participants. My question is for you, Professor Mishara. You closed your presentation by referring to data from the Netherlands. Could you elaborate a bit on that? You're talking about exponential growth after 1 or 2, 3 cases a year, and now it's much larger numbers. Could you explain that, give us more details, and give the committee the source of this information? I could send the references. In the Netherlands, they have a long assessment process. It can last up to 2 years. They accept 3% of the requests, and even that is controversial. But suicide is a phenomenon. There is this phenomenon called the Werther effect because of this book by Goethe, The Tribulations of Werther. When it was published more than 200 years ago, there was an epidemic of suicide in Europe afterwards, in all countries where the book was published. These were young people. I'm sorry, my time is short. I'd like you to get back to the statistics you gave us. Could you talk to us about the concrete experience of the Netherlands? The phenomenon is when there was publicity about the suicide methods. The number of suicides increases in a given country with people who have a mental illness, who are particularly vulnerable, and who use that method. It's not a substitute, but these are people who wouldn't have died if that publicity hadn't happened. And what happened is there were photographs and descriptions. The case of a young woman who received MAID for depression. And because this was publicized in the subway in Montreal or on the Jacques Cartier Bridge or in the metro, but the numbers, once again, the trend was an increase right away. I only have 15 or 20 seconds. It increased to the figures that I gave you. Within 1 year, instead of 2 cases, there were 238 deaths. The following year, 219. These were young people, mostly young people, women who lived alone, who had a diagnosis of depression, clinical depression, and who made those requests. And the idea is that the message that's communicated to suicidal people is that this is one way to treat your depression. Thank you. Perhaps you could send us that study. Okay, thank you.
Moody for 3 minutes.
Mr. Chair, Dr. Mishara, I have to come back to this because I'm puzzled by what I'm hearing. I want to put a scenario to you. This committee has heard testimony that here in Canada, we should not allow persons with mental illness as their sole condition to access MAID, even when they are suffering intolerably, even if they meet the criteria required, and even if they wish to end their lives, and would and will do so if they do not get access to MAID. Do you share this view, Dr. Mishara?
I do not at all share that view. I have spent my life working in suicide prevention. I have started helplines in different countries, in Montreal. I've worked on the line.
Another question for you, Dr. Mishara. You'll get a chance to answer.
Okay,
Is it your view, Dr. Mishara, that people who are suffering intolerably, who have tried all appropriate levels of treatment, all appropriate supports, all of which these individuals deem to have failed, who continue to suffer, is it your opinion that they should keep trying these failed treatments? They must wait for the realization of some research to come in the future, perhaps. They must continue to live with this intolerable suffering. Is this your view, Dr. Mishara?
I believe that, first of all, the treatment for suicide involves a human being caring about them and believing that they can find hope regardless of this hopeless situation they feel they are in, and embarking with them on helping them get help and support they need. If you look at the reasons people give, it is not because of the symptoms of their illness. It's often because of loneliness, inability to be in a relationship and have a job, feeling the stigma of a mental illness and its impact along those lines. If you look at the reports of why people are asking for MAID, even not for mental illness, it's almost never pain, like physical pain. It's an emotional suffering which is equally a result of living in our society where when you have a mental illness, you can't get a good job, you don't, people abandon you.
Thank you for that.
Thank
I
you.
just have
Thank
one
you,
more
Senator.
question.
Your 3 minutes is up.
Okay.
Senator Osler for 3 minutes.
Thank you, Chair, and thank you to both witnesses for being here today. My question, I'm going to start with Dr. Sockalingam and go to Professor Mishara if there's time. This committee has heard testimony from different experts on what they think patients should do, and less from patients with lived experience, particularly those who are in support of MAID where mental illness is the sole underlying medical condition. It's a two-part question. First question, Dr. Sockalingam, are you aware that there are people with lived experience with mental disorders who have publicly stated a willingness to bring a different perspective than those who have been invited to appear before this committee? Second question, would you agree that having people with lived experience, with a diversity of views and experiences and expertise before the committee would allow the committee to better meet its obligations to make recommendations on this difficult issue?
Thank you for that question. I would say in my experience, and again, in the process of our own journey at CAMH in our recommendations and statements to previously and currently, we have tried to engage the most diverse patients, including people who have stated with lived experience that they're in support of MAID for mental illness. I think we are still left with the challenge of we're not arguing grievousness from that standpoint, but the definitions of irremediability and the differentiation of is that request occurring or people seeking MAID in the context of their mental illness, is that differentiated or can that be differentiated from suicidal intent as part of the illness itself? So I think from that standpoint, your question is, should we include people? We should always, and we have tried to at CAMH as well. So I would agree. I still think we are still stuck with some of the, as an assessor for MAID, I'm an assessor for MAID, that I am still stuck with the struggle based on the lack of evidence or guidance or objectiveness to feel comfortable that we're making a decision and be able to prognosticate for an individual what their long-term course would be. So I think that's the tension here. So the answer is yes, we should have diverse views.
Thank you. And from what I've heard from you, you said, yes, you're aware of people with diverse opinions and lived experience, diverse opinions. And at CAMH, you did try to hear from a diversity 100%. Of patients with views.
100%.
Thank you. And Professor Mishara, same question to you.
Professor, you only have about 5 seconds. So briefly, Anthony.
I appreciate how much people care about the suffering, but suicide prevention works, and every single person who I have spoken to and with who is suicidal felt exactly like described,
I understand,
and
I
they got
cut you off. I know
most
we're out
of them
time,
got hope.
But my question was about centering.
Thank you, Doc.
Thank you.
Thank you, Senator Osler. Your time is up. Senator Wells for 3 minutes.
Thank you, Professor Mishara. In your previous testimony to this committee in 2022, you stated that in the Netherlands, only 5% of MAID requests for a mental disorder are granted, and that even in, quote, even in medical cases of terminal illness, 40% of the requests are refused because the doctor believes there are ways to treat suffering, and hardly any of those refused repeat their requests after trying the treatments, end quote. So my question to you is this: if you know whether these statistics are still the case in the Netherlands, I think you went into that a little bit, and if so, wouldn't that demonstrate that the Netherlands actually has a robust safeguard system for MAID MI-SUMC that Canada can learn from?
Well, even though that's gone down a little bit, it's 3% of the requests are for MAID for mental illness are approved now, but there is one clinic which gets 85% of the requests, and they approve 13.6% of their requests. The problem is that this was sort of under the radar. There were a couple of cases.
Too much into that. That's maybe not relevant to our example here in Canada. So the question was, is there anything you think we can learn from the Netherlands experience? You said MAID requests are actually going down from the Canada experience.
Well, they're not. The number for mental illness is skyrocketing now. But and the number the percentage they're approving has gone down about 40%. But the number of it's gotten to the point where it's an epidemic of young people mostly.
I only have limited time, so you don't think there's anything then Canada should take or learn from their
Well,
experience in the
there's a
Netherlands?
danger to offer MAID for mental illness because this communicates to a vulnerable population where in many instances suicidality is a symptom of their illness. The desire to die is a symptomatic of the illness, and what it's caused is a phenomena where it's being considered an alternative to treatment.
Are you saying that talking about MAID can lead to a contagion of people wanting to pursue MAID?
Showing any death by suicide or by MAID for someone with a mental illness to vulnerable people who have a mental illness and have considered suicide and will increase the number of people who will die by that method and the number of people who wouldn't have died who would then choose MAID. This happens if you talk about a suicide on a bridge or the metro or someone with a mental illness.
So is there actual research that focuses right on MAID?
Senator, your 3 minutes is
If you
long.
could send that to
Senator,
us.
your 3 minutes. Yes, if you could send us all of these studies from Holland, we'd be, as we previously mentioned, we'd
I
appreciate
shall do so.
We go to the second round of questioning. Mr. Cooper for 3 minutes.
Thank you, Mr. Chair. Dr. Sockalingam, consistent with the testimony of other psychiatrists who came before this committee, you indicated that there is no specific scientific way to predict the future course of mental illness. So, given that, would it be fair to say that any prediction would amount to a clinical hunch?
I would say clinical judgment is where we are basing any kind of prediction at this current time. And as I said before, there's research underway for several years to try to explore indicators to help us prognosticate better, but we're a long way away.
And it would be fair to say that it's quite common for psychiatrists to disagree amongst one another on the future course of mental illnesses. Is that fair?
I would say so, and even the diagnosis itself, as others have highlighted as well, that there are studies showing differences, including from the initial field studies of the DSM-5, for example, that there are differences in diagnosis and that they change over time.
And so given the difficulty in predicting irremediability, the fact that there is no scientific objective way, would it be fair to say that if this expansion were to move ahead, there would be a high rate of error in which persons who could get better, who could go on to lead a healthy and happy life, would have their lives prematurely ended? As Dr. Sanu Gained said, it would be akin to flipping a coin. Would you agree?
I would say we would be using clinical judgment, and there would be, if we were to go forward, that there would be times where there may have been a chance to provide treatments that people may not have had access to or not been aware of, and that there may be times where people's illness may have improved, but we may have predicted incorrectly.
And you spoke about the CPA guidance, and you noted that it fails to provide any scientific criteria with respect to predicting irremediability, likely because there aren't no such criteria. The CPA guidance does use the practice standard from Health Canada, but that looks back on a retrospective basis. You would, I take it, agree that that's insufficient?
That is insufficient, and again, the CPA, I applaud the CPA for trying to come up with guidance, but we're limited by the literature and the evidence. And the evidence is based on retrospective data, and it's a process document as opposed to a criteria or an objective assessment.
Thank you. Mr. Maloney for 3 minutes.
Thank you, Chair. Thank you to both of our witnesses. Dr. Sockalingam, I will continue with you. You said at one point that any such diagnosis is entirely subjective when it comes to mental illness, I believe. And is that because, do you say that to some degree anyway, because the symptoms are subjective?
Well, the symptoms are not subjective, and I wouldn't say entirely subjective. We have diagnostic criteria that are based on symptoms and have evolved over time. But I will say we don't have objective markers. We don't have a test and those markers don't necessarily are limited to diagnosis. They're limited to even prognosis. For example, in certain neurological conditions, in cancer, we can prognosticate who's going to respond to what treatment for how long and what their duration of illness might be, and where death might be.
I think we're saying the same thing. You just put it much
Yes.
better than I could have. I mean, when people come to you or another psychiatrist with a mental health condition, you're relying on information that they are conveying to you verbally. There are some indicators or some markers that you can use, but unlike a physical medical condition where there's an MRI or an X-ray or something, there's not as much physical evidence available to you as a diagnostic tool. Is that right?
That's correct. We have some data points, but nothing that would definitively be something we can hang our hat on for this particular discussion today.
And that's what's going to lead to the inconsistent diagnosis that Mr. Cooper was alluding to, because if somebody has terminal lung cancer and 10 doctors examine that patient, they're all going to agree the patient has lung cancer. If 10 psychiatrists examine somebody who has a mental health condition, you're going to get different diagnosis, aren't you?
That is correct. It happens in our clinical care. When people are
and
admitted to
very
different
rarely are you going to get 10 out of 10. It could happen, but it's very rarely, and it's not going to happen in the vast majority of cases. Is that fair?
That is correct.
Okay. All right. So I want to talk about another thing. We've been talking about consensus at this committee quite a bit, and I think at times people are confusing ethical consensus with medical consensus. In the condition where I'm talking about with the lung cancer, you will get a consensus, and if there is a lack of consensus in the medical community or in the general public about whether to proceed with MAID, it's basically on an ethical issue versus an immoral issue. Whereas when you're talking about mental health, really the consensus you can't achieve is the medical consensus. Is that fair?
That was what I was referring to in my statement. Correct. It's the consensus on irremediability, consensus on differentiating suicidal intent versus a request for MAID or persistent desire to die.
Which takes me to my third point. Okay, we're talking about equal rights on MAID for people with mental health versus physical conditions. Everybody agrees they should have equal rights, but lacking the ability to have this definitive diagnosis, it's hard to provide that those rights are safe. Is that fair?
Exactly. It's safe, and I would just underscore the accessibility.
Protected is a better word, yeah.
Yeah, protected, and also the accessibility of treatments that are effective.
Thank you, Mr. Maloney. Madame de Bellefeuille pour 2 minutes.
Ms. de Bellefeuille, 2 minutes. Thank you, Mr. Chairman. Professor Mishara, we agree that not everyone who has a mental illness problem has suicidal ideation or wants to commit suicide. We have agreed since we talked that there's a close link between a mental health problem and a desire to end one's life. In my practice, I've met people who have mental illnesses, and that's their only illness, and they don't think about suicide. They want their suffering to end. They want good treatment. They want to get good care. So it's not necessarily a cause and effect here. Sometimes I think that some want us to think that to prevent MAID for people whose only diagnosis is mental illness is automatically linked to suicide. So am I wrong to think that not all people who have a mental health issue think about suicide? Is it normal that a person who has attempted suicide, who has been treated, listened to their psychiatrist, took their medication, could have the choice of dying with dignity. It's not the same thing. Seems to me we're confusing things, Professor Mishara. We're creating links that seem to me a little tenuous. I'm sorry, I'm going to wear my researcher's hat again. The research indicates that in Canada, over 90% of people who commit suicide had a diagnosis or could have had a diagnosis of mental illness. Okay, well, therefore, 10% don't have one, and they have rights. Thank you.
2 minutes.
Mr. Chair, my question is for Professor Mishara. Would you agree that a parliamentary committee tasked with making recommendations on this important and complex issue should have before it not only the full range of expert evidence, but also patience?
Point of order.
Point of who is it?
It's mine.
Mr. Long?
Mr. Chair, I'm rooting this in Chapter 20 of House of Commons Procedure and Practice. This committee had set out through the work of the subcommittee a very robust plan, including people with lived experience. The scope of this committee is not to review or ask witnesses to weigh in on how to structure parliamentary committees, which is what the senator is now devoting her second round of questioning to. So the line of questioning is out of scope, but it's also misrepresenting the facts of how this committee is undertaking its work.
I would suggest, that, and the chair has some discretion over this, I think the line of questioning is broadly related to the topic under discussion. She has briefly 1 minute and 35 seconds left. I don't think it's going too far out of line to let her ask her question.
Thank you, Mr. Chair. So to be brief, Professor, to allow you the optimal time to answer, can you tell us about hearing from, in your experience as a researcher, hearing from patients with a diversity of experiences?
It certainly enriches our understanding of how to proceed and better help people because it gives a sense of their whole life and all the complications of their life which are associated with their suffering, because the suffering with someone from a mental illness, I agree it can be just as acute or worse than suffering from a physical illness, but it is not because of the symptoms that are usually. It's usually because the whole constellation of living with a mental illness and frustrations and getting help and so forth. And it's more complicated because many diagnostic categories, diagnoses, one of the symptoms, like of depression, is hopelessness. It's a symptom of the illness, so that no matter how good things seem, you're going to think it's hopeless. I'm never going to feel better. And this is related to the illness, which is not being adequately or correctly treated at that point in time. So it certainly can point to things a little out of the technical scientific discussion, but as a society, how can we better help people with a mental illness so they won't feel so desperate, not just in terms of mental health treatment, which is very difficult to get in Canada, but also in terms of all the other aspects of the life of someone with a mental illness, which is profoundly influencing their ability to live and have a good life in Canada despite their illness.
Thank you, Doctor.
I have a point of order as well, just before we...
Point of order.
I just want to make sure I correct the record. Last night, we had someone with lived experience, so we need to correct the record from what the senator just said. Thank you.
Point is noted. Senator Wells for 2 minutes.
Thank you. My question is for Mr. Sockalingam. Since the Canadian Psychological Association wasn't invited to this committee to discuss their guidance, I want to ask you, what is CAMH doing to develop the objective markers to determine the mental health condition required?
Well, CAMH, I'll take that in two parts. So CAMH, one of the reviews cited came from CAMH, and the recent review is under publication on the difficulty of differentiating suicidality versus requests for MAID. And so that's part of the work we've been undertaking in the last couple of years. And we have another review and synthesis of the literature on irremediability that has informed our statement. Secondly, we are a research, academic research hospital, and we are conducting numerous studies, including looking at youth and following youth over time to look at trajectories of people and differentiation of illness, and also looking at more personalized care in terms of treatment response. And then lastly, we are leading, and including just yesterday, published a paper on treatment-resistant depression and treatments and what can be effective for people who have not responded to other treatments before. And we will continue to do that research and work to develop those treatment options for people who may not have responded to many of our traditional treatment forms.
Great, thank you. Do I have time? Okay, thank you. Dr. Sockalingam, you said in a New York Times article published in 2023 that CAMH has been clear that we have concerns about expansion at this time when talking about MAID for MI-SUMC. So based on your testimony today, are you correct that you still don't feel that we're ready for this extension? And if so, do you think Canada will ever be ready?
I'll just reiterate my statement. I do not think we are ready at this time, and I don't think so in the foreseeable future, to be honest, because we do need further research, evidence, and to evolve our approach for both assessment and treatment for mental health, both as an individual and for the system at large. Will I say that ever? I won't go that far. And I'm saying we can't predict the courses of mental illness. I'm not going to predict the future of psychiatric research at this time.
Thank you. Thank you, Dr. Sockalingam and Professor Mishara, for your valuable testimony. We appreciate your coming out tonight. And with that, we'll suspend and wait for the next